any structural problem on imaging with this group of patients?
With this group of patients, we did not see any structural defects which could explain the severe instability our patients display. We saw some deficiencies in up to 30% of the cases in the first cohort study. We had some glenoid flattening or some increased retroversion or one case with glenoidal dysplasia. These were the cases where the treatment was not so effective, and the other cases were normal in MRI imaging. No structural defects.
Have you ever tried this modality in the patients for rehabilitation after surgery? Because when we operate, usually deorganize completely the shoulder for a period of time, keeping him immobile or partially mobile, and then we have to have the patients to learn again a skill to move the shoulder.
So we also receive patients where we see structural defects, but believe that they also suffer from a muscle disbalance. And we now collect these patients, we operate them, and they also will receive the pacemaker treatment. But I cannot give you any data on this right now because we are just collecting these patients.
So what will you do for the multidirectional instability? And again, like, is there any chance of recurrence after the pacemaker treatment?
Sorry, could you repeat?
No. What you showed us that AMS pacemaker treatment mainly for the posterior shoulder instability. What you will do for the multidirectional instability? And again, is there any chance of recurrence after the pacemaker treatment for the?
So as I've said, we had cases with recurrence of instability. We included only patients who suffered from positional posterior shoulder instability because it worked the best with these patients. And the treatment was less effective in patients who showed these deficiencies and worked the best in patients who were athletic and actually have a better feeling of their overall body.
Okay. Have you found any recurrence after the pacemaker treatment, maybe 2 years, 3 years, 3 years down the line?
Yes, so we had the 1 year follow-up, and in this 1 year follow-up we had 2 cases of recurrence. So one was traumatic and one was actually atraumatic. So one case of really recurrence of instability, and we are currently collecting the 2 years follow-up.
Okay. Okay, thank you very much.
Thank you.
I have a question for you also, to be original.
Where is it?
It's me.
Okay.
So, from my understanding, the patients with an indication for this pacemaker are really limited. These patients in your cohort, did any of them not have any kind of prior physical therapy, or is this also indicated mainly indicated for failures in previous physical therapy? Because I understood there was a case that did none before.
So the first study where I showed the results from 1 year, they all received at least 3 months of physiotherapy. And we tried to collect a negative selection of patients. That means that they already received 3 months of physiotherapy. In some cases, they already even received surgical stabilization attempts. And these are the patients we collected and treated with our pacemaker treatment. What we want to do now is that we want to have a control group, which we didn't have before because we just had negative selected patients. And this is what we are currently conducting in Germany and Switzerland, where we include patients, randomize them into one group which will receive the EMS or a pacemaker-based treatment, and the other group as a control group who will receive the same exercises and same treatment protocol, but without the electric muscle stimulation, so that we can really compare what works the best. Is it an intense physiotherapy which really aims for strengthening the rotator cuff and scapulothoracic muscles, or is it the combination of physiotherapy with electric muscle stimulation?
Okay, but only for functional shoulder posterior instability?
Yes.
Only in these cases?
Yes.
Okay.
Yes. Which has been observed as the most common subtype we had in our cohort, because we collected for more than 2 years all patients we received with atraumatic instability or atraumatic multidirectional instability, and this is why we also performed the fluoroscopic imaging with all these patients. And what we saw is that most of them displayed a unidirectional posterior positional shoulder instability.
Okay, thank you.
Another question? I would like the final question. As we saw, Alex, our rates of recurrence are improved through the years, and I believe that this is due to our techniques, our experience, and in the first 2 or 3 dislocations, the recurrence rate are almost 5%, okay? How to convince the patient to do it? I mean, to operate the first operation. How difficult it is for you to convince them that if you do it in the first operation, probably you don't have a bone loss in the future, and you have good results which reach to the normal functional of the shoulder. Because it is very difficult. It's a big difference between the shoulder and the knee. When you have a dislocation in the knee, the patient comes to you and say, I don't feel well when I turn around. But in the shoulder, the first or the second dislocation, they can tolerate this disability.
Well, Nico, I do not want to convince anyone. I just tell what I said before, what we said all the time now. Say, listen, you have your joint that is dislocated. It is not a rare disease, and it was described by Hippocrates many years ago. So don't be concerned about it. I mean, it is just an event of your life. But when you have this first event, you are weakening a system that is already a little weak by definition. So you are at risk of recurrence, and every recurrence will damage more your structures. And this will also influence the possibility of the success of the treatment. So if you really want to take care of it, because you are young, active, blah, 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 I advise you to take care of it soon, because we have the best results. If you want to keep the way it is, we will see in the future, but remember that nothing, I use this statement with the patient, nothing is improving while the time is going by but the good wine. And so understand, yeah, this is the truth. Nothing will improve if you keep it this way, just the good one. The bad one is not that true. So if they understand that, and if they are motivated, because at the end it is a game of 2 people, the doctor and the patient. And the patient must be motivated. So I explain them clearly, without pressure, and if they want to do that, they need to understand this. Otherwise, they do not participate into the program. But I don't have any magic recipe.
Thank you.